I'm the program manager for the Wise Women portion, mostly of the Ladies First program. But I also cross over and end up helping out with sort of all of it. And so, I don't know, I've been working with Kristen a lot on the navigation piece and trying to figure out how we better market and do outreach of Ladies First around the state. And Carrie.
My name is Carrie Frenier, and I also work with Nancy with the Ladies First program on both sides, the breast and cervical and the Wise on the side, the heart health screening component, as well as primarily in the professional education arena, and also a little bit in communications and also working with comprehensive cancer.
Thank you. And so we're here today to talk about Ladies First codes and some new codes that came out and how they may be applicable beyond just the clinical services that are provided, but largely focusing on the clinical services that are provided as well. So I'm going to let Carrie, who is the expert on this one, take the lead.
Sure. Thank you, Kristen. Okay, let's just get the slides up here and we'll begin. Like Kristen said, it's really giving you an overview of 2015. What is new with the Ladies First program and what is being driven by the American Medical Association in terms of changes to clinical procedure terminology. But I'll kind of move along here and give you an overview of what we're going to cover today in the presentation. Okay, so what we thought we'd give you as a 2015 update is kind of discuss what's changed in terms of clinical reporting to the Ladies First program, what is a little different than we've done in the past. I know this is a transitional process and it's not going to be something that's going to be happen overnight, but it'll be a progressive change, so I'll cover that. I'll also talk a little bit about our main billing service, which is HP Enterprise Services. Often I hear billers around the state saying Medicaid. That is a true statement, but in a way, but Medicaid is a client of HP Enterprise Services. So let me describe that a little more in detail to you. Then we'll cover a little bit about the eligibility verification system, how important it is to the FQHCs that they use this efficiently and effectively, and required Ladies First policies in terms of claim submission. Also talking a little bit about timely filing and billing the patient. And we have a little bit of new news around this arena because we want to do some reconciliation for past bills. So it gives an opportunity for each facility to do some audits and maybe get some claims into us. And then banner pages, advisories, and RAs. Some of these things are great resources for your billing people to keep up to date with our program as well as DIVA. And then kind of your hotline to us is the Ladies First support line. So first, let's talk about clinical reporting. In the past, the Ladies First program has had a reporting mechanism they've utilized called the health checkup form, and that's what your facility or practices are most familiar with. And this form is usually filled out at time of visit for the patient. Of course, the patient is already designated as a Ladies First member, but when they come into the practice, the clinician sees the patient and then should be reporting on this form to us. In the ideal world, it would be great if we had an electronic system that they could data enter information into right away. Some facilities have taken our form and put it into their electronic records. That's really a good plus. But my purpose of talking about this today in 2015 is that we've changed the report. The health checkup form still exists, but we have a new provider report form. And here is a quick down and dirty summary of what's changed. We gave it a new name. It's no longer the health checkup form, because in the past there was a section of the report form that the patient had to fill out. They were health questionnaires, health questions primarily for data collection for the heart health program. We've taken those out and we gleaned those from somewhere else, and now it's more of a streamlined report just for the provider, so we changed and said provider report. It also updated information that we're collecting for CDC, as well as a little bit of extra information that is the intent to improve quality of care, and also the option for practices to report the data to us. Now, this means that the report might be sitting around more than 10 days to report back to us, but we still feel that it's worth it if it can sit, and then you enter in the data. And the data meaning the result of the pap smear, the result of the mammogram, and the result of the blood work. And also there's a little perk throughout into the presentation I'll talk about that will be a benefit of filling it out in this regard. Also, the report highlights sections where you would report clinical results, and it says, it sort of brings your attention to alerting you to the fact that it's important that you contact us, because we need to get that patient into patient navigation services. So that's new, and it's important that that connection be made. Once you know there's an abnormal result for breast screening or cervical screening, or even an alert value for the heart health side of the program, that you contact us. So jumping into our contracted billing service is HP Enterprise Services. A few years ago, Ladies First moved to this service because here at the health department we could by no means process claims and keep it HIPAA compliant and be able to allow providers to electronically bill us. We were always a paper-based billing processes here at the health department. So we knew that HP was much broader in terms of opening up billing services to many programs in Vermont and grants and services like Medicaid, Healthy Vermonters, several other healthcare programs in the state, and had a very sophisticated billing system, and which is going to be updated soon. So we knew we wanted to have our billing processes with them in a secure system, and a huge staff to maintain credentialing for providers and making sure that claim processing happened efficiently and effectively. And this kind of gives you an overview of how they capture and receive claims, and they're scanned with optical readers. We don't even have that technology here, and this was years ago. And they document everything in file, all of the provider certification papers there for easy retrieval, and so it's a great network to work with. So when working with HP, which we would never have this type of portal available here at the health department, but when they process claims, they have an excellent way to communicate to your practice and telling you what exactly the patient is eligible for. Do they have that patient in the system in order for the practice to be reimbursed? There's no sense of a practice submitting a claim without using their system, and they can't emphasize that enough. And they're also a biller for Medicaid, and obviously if your practices are familiar with Medicaid, that they say mandatory that you check the verification system before submitting any claims. Basically, the systems tell you if the patient is on Ladies First. Makes sense. If you were to bill and she wasn't, you wouldn't be paid, and that claim would be denied, and it just goes into a cycle, and there's no sense to keep resubmitting because the patient is not in the system. So they have a voice response system, and they also have a portal. And I think I have a picture. Well, here gives a summary of what access means. It's available 24 hours a day, 7 days a week, unless they have routine maintenance, and they announce that on the portal as well as their banners weekly. They respond quickly in terms of once that patient's in the system, it's pretty, I guess their turnaround time is 24 hours. So if we transfer data to them from our program, it's a 24-hour wait, and that person should be live. So that's pretty quick. It minimizes risk of non-payment for services, and a lot of practices are now electronically submitting bills. It's quicker, faster, and you can get reimbursed more if you're an electronic biller as opposed to paper biller. And it decreases the amount of denials that you'll receive. Here's a picture of it, the portal. So when you go in and take a look and to verify if the patient's on the program, here you can see there's a coverage description and the aid category. If the patient has the aid category LF, that means you're good to go. You're able to submit a claim. The other two aid categories you might see, which is very important for billers to understand, is yes, Ladies First is a screening and diagnostic program, and then we refer to our treatment program, which is primarily for breast and cervical and precancerous conditions, not heart health conditions. But that program, when a patient is on that, you might see the aid category of BG or BH. So checking the EVS system is essential, making sure that you follow the proper billing procedures in terms of claims. There's only a few policies that we have. With Ladies First, you would bill just like you would with Medicaid. Oftentimes, the billers out there in the world have issues, and I know this came up with the Community Health Center of Rutland Region, is you may have a clearinghouse or a middleman that you send your bills to, and then they send on to HP, and you might have glitches there when there's new procedure codes or updates to diagnosis codes. I just wanted you to know that there is support out there for things like this, and there's provider reps, and these are the provider reps statewide. So if you see, like in the Rutland area, Paula Martel is the support person. You always can contact those individuals, and those individuals are pretty savvy about Ladies First, not as much as we are or I am. So I encourage you to call me if it's particular to Ladies First. But if it's a systems thing and your clearinghouse or your software is not interfacing properly with the HP, I would definitely call the provider rep at HP. Also, a lot of the practices may be using the billing software that HP provides. Another perk of working with them is they update the software every year, and they provide it free to all the practices. So what are the policies that are different than Medicaid? You would bill Ladies First just like you do Medicaid. The way we built the billing process within the system is that when a claim comes in, and that particular name is going to trigger Ladies First. So then it goes into the Ladies First basket as a descriptor as you're going through HP. But there's certain things within the claim, and forgive me, this is the old CMS form. There is a new CMS form out, but just to illustrate it as an example of what our policies are. We still have 3 important policies when you submit the claim. This is a CMS 1500 form. We're still asking practices to split the claim if there's an insurance payment on the service. So if the clinical procedure was something that the patient had other insurance and there was a payment, that's when we ask you to split it out. If there's no payment, you do not have to split the claim out. That means a claim for each procedure. Another policy for claim submission is to use the pointers to our covered diagnosis codes. And Ladies First has just completed their 2015 schedule of fees, and within that schedule are a listing of diagnosis codes, and those are ICD-9 still. And we ask that you use those codes within those within box 21, and you can use other codes, but just don't point to them. So for this slide in box, let's see, it is number 24E. It says diagnosis pointer. What we ask you to do, and I think you have an option now with a new form, is to fill in 10 diagnosis codes. But we just ask you to point to the one that Ladies First covers. Another policy is to, which this is important, and I know on HP's portal there is a slide presentation that I did on modifiers. With clinical procedure terminology, there are modifiers for certain procedures, and Ladies First has the rule that you have to use the TC, which just means technical component of that procedure, as well as 26, which means the provider component. Those are the only 2 modifiers that we require. Now, note within your own practice that other insurers may require multiple modifiers, but these are the only 2 that we require and are really driven by CDC. Now, there was a DEVA, Department of Vermont Access, did an audit this past year and found that primarily facilities were not using the modifiers like they should, like mammograms, the difference between technical component and 26. There is a third, which is called the global billing, which is a combination of both. So global is the total cost of the procedure. TC is just the technical component. For instance, if we used it as a mammogram, would be those who take the mammogram, and then 26 would be those who read the mammogram. So it's important that the facility and the provider delineate between the 2 and use their modifiers so everyone gets paid accordingly. We can't be overpaying for procedures, giving global to someone that is not doing the entire service. So that's why we have that rule of using TC or 26. So sorry about this additional banner up top here. It's just a repeat from the last page, but here moving into, so those were our 3 policies for Ladies First that need to be done, which is not a big deal. We don't see a lot of payment on insurance for women in our program if they have it. Most of the time it's not, you know, there's no payment because they haven't met their deductible. And then the modifier is not really a big deal. Most places have it built into their system. And then the first one, the splitting of the claim, right. So here are the other rules that are the same as Medicaid. We have a 6-month timely filing limit that you have to get your claims in. within 6 months. So this is where I'm going to announce some news to you all, and we'll pass this on to other practices, is we're going to be doing a reconciliation project this month, February, where we're going to extend an invitation to all the practices to query their systems. And sometimes this is a good process, even if you have turnover, to go try to look back and see if you identify your Ladies First patients, and also if there's anything outstanding that you haven't billed us. And we're going to go back 1 year. 1 year to allow you to do this, and then get a listing of claims to us. And there'll be some emails going out to everyone about it. But now you know, you're going to be the first set to know. And then send on those claims, and then we're going to do some manual payments on that. So that's really good to do, to clean up your books and everything. The claims billed to a primary payer must be filed within 24 hours from date of service. True. 24 months, I mean, from date of service. So that's 2 years if they have other insurance. When HP deny claim within the timely filing limit for a reason other than exceeding the time limit, a copy of an RA showing the denial must be attached. And all claims that file have a timely filing edit and are in suspension for me. I review them anyways. And if I have an issue, I will contact the practice, but I'm going to go ahead and force pay those more than likely. We don't have a rule right now that says we won't pay back claims. So I encourage you, if you do get a denial, to call me and we can do a manual payment on it. Just like I said at the bottom. So if it's untimely, call me and we'll see what we can do. So jumping into the new updates for the Ladies First fee schedule, I should have the new fee schedule posted to the provider training website that you all should know about. It's www.ladiesfirstproviders.vermont.gov, and you go to the FAST forms, and the new fee schedule should be there soon. Just waiting on some approvals. But within the fee schedule, you have a full listing of what we cover in terms of clinical procedures. You have our quality codes, which I'll talk about in a minute, as well as your diagnostic codes, and something else that's not really relevant to you folks, it's more for facilities, is rev codes. Now, important point to realize too is that we pay out at the Medicare Part B rate. Those rates have gone slightly down in 2015, but some procedures have slightly gone up. But this goes along with this huge, well, there was a legislation passed, there was going to be a huge reduction to providers. But this is just a modest pennies change in the amount that we're reimbursing. So you see things drop, but it's not by much. So big update. According to the American Medical Association, there's been some deletion of codes, and these are important to note because they have to get out of your system. So first up is the ultrasound procedure 76645. This code has totally been wiped out. So it cannot be used anymore. And you got to check your systems to see if it's been loaded in. And so it's now deleted. And the reason they do this is because they've created some new codes that are more specific, meaning whether it's right, left, unilateral, bilateral, whatever, they've created this. So here are the two new codes that are on our list, is 76641 and 76642. So those should be in your systems, even for Medicaid and everything else. These codes are uniform. It's for the uniform claim submission, so it's national. Everyone is using the uniform claim form as well as these national codes. Also that changed is the HPV. And it used to be 87621. That's been deleted, and here's the new one. And the same for immunochemistry. You'll see those two G codes that have been deleted, and these are the two new ones for our program. And again, of course, CDC has said these are allowable things that we can cover. In the past, on our fee schedule, note at the bottom, these three codes, 88143, 88174, 88175, were capped. We couldn't pay at the normal rate for these codes. We had to offer other code of 88142 rate. That has been dropped. We are now allowed to reimburse at the Medicare Part B rate for those individual codes. New services for the program, and it does reflect on our provider report form, is really emphasizing the importance of risk assessment. And this crosses between the heart health component of the program as well as the breast and cervical component, is just realizing that how important it is to assess a patient when they come in during the office visit, meaning around their heart health as well as their family history and BRCA related risks. And this goes nicely with the U.S. Preventive Task Force in terms of the BRCA related cancer risks, is the requirement and encouragement that providers do this with every single patient. So we will pay providers this code 99420 in order for them to do this assessment. And one big theme among primary care providers is, I'm spending the time, am I going to get paid for this? Yes, you are, from Ladies First. And the non-facility rate is $9.14 per patient to spend the time to do a short, quick assessment within the office visit. So that is billable along with the office visit. Also included is, which takes it a little step further, is risk reduction counseling related to the heart health side. And the definition for counseling, as Nancy has prepared, is it includes screening results verbally and in writing, providing interpretation and recommendations, using motivational interviewing, and making referrals to medical follow-ups. And also to our new lifestyle programs, which is like Weight Watchers, YMCA Diabetes Prevention Program, and CURBS. So it's not saying, you know, it's saying our hope is we'll reimburse for this, but as long as the provider includes all of this. I have a code for that, and that you would normally code under these green codes, 99401, 402, 403, 404 for that type of service based on time, 15 minutes up to 60 minutes. Oops, I go too far. Yeah. So for BRCA counseling risk reduction, U.S. Preventative Task Force has created, at the time they said it'd be great for all providers to do this and assess family history for BRCA 1 and 2. At the time they said they have to use tools. At the release of this guidance, only one tool was available, and they were developing the rest of them. And we also can make a summary of these tools available post webinar. But within our provider report, we've already included this assessment. It's called FHS 7, and it's just 7 quick questions that a provider can ask a patient and document in the medical chart. But this gives us an idea if the patient is considered high risk and needs referral to either the genetic program at Fletcher Allen or the University of Vermont or Dartmouth. And these are the codes. In the past, we have had these codes, and that is considered where this kind of activity would be reimbursed or through these office visit codes. Something new. We have a more lengthy provider report where one can report clinical results. So in order to encourage this activity of reporting to us, maybe holding on to the report a little bit longer and getting that data back to us, we've introduced a new CPT code 99499, which stands for Evaluation and Management and Reporting. And we'll be reimbursing $100 for every report on each patient that a practice submits to us. Keep in mind that these codes are going to suspend for our review, so we can still quality check to see if that data is in before reimbursement occurs. In addition to the $100 reporting on each patient, we have new quality codes, and in the fee schedule we had those last year as well. But these quality codes are kind of aligned with other national performance standards like HEDIS and various others like patient-centered medical home. To encourage you to be practicing to reach your performance measures, we'll reimburse $40. For example, if you take 2 blood pressures, if you document in the chart when the woman's due for their next mammogram. So it's important for you to check out those quality 2 codes because they do only apply to the physician side of the practice, not facilities. It's for the primary care provider. If they're, if they're doing a height and weight, taking weight, if they calculate BMI, which are true benefits to our program as well, we'll reimburse you $40 per code. Here's an example of some of the codes, and they're listed here. They're a 1-page listing, and I did check. There's no new codes, quality codes for 2015, so basically there's the same ones as last year. And we have seen some really good use of these codes, and I'm really impressed by some practices in the state that they've really understood that. The billing section has communicated that to their providers. We also pay in 2015 for MRI, and this gives you an idea of what we pay for. We don't pay for MRI for screening. So in conjunction with a mammogram, when a member has a BRCA mutation, a first-degree relative, which is BRCA carrier, and has a lifetime risk, is when we cover that. And those codes are also included on the fee schedule. And it just gives you a little more detail on what we do cover. So moving on to your resources for updates. We were just talking about this the other day with HP. Right now, there's been a system glitch within HP that the system is pulling copays, $3 copays from your reimbursement statewide, and we're trying to fix that. So that's why it's important to check banner pages through the portal. What's new, what's going on, because that's where we're going to announce what the problem is and how we're going to fix it. So it's always good for billers to check into the portal banners each week, and then they'll learn everything else that's happening with Medicaid as well. And also, there is an advisory that the Department of Vermont Health Access puts out and puts all the new updates and things as well. So those are 2 great resources for billers to keep updated. And then, of course, calling the Ladies First program. for support. You know, remember the regional provider reps for more systems issues. And if we're not in, if I'm on vacation, you also can go to them. And then they also have a provider support line at HP, but also you can call me if you have questions about the claim and why it's not being paid, and if it's over time limit, that we can work together with doing a manual payment on that as well. So that ends my presentation, but I wanted to open it up for chat boxes and questions or chat messages.
This is Jean at Morrisville. I just have a question. Maybe I don't really know. So oftentimes we don't catch these people until they're actually in for those appointments, for whether they're scheduled for a PAP or a breast exam. So at that point, I would be doing the intake with them to see if they would qualify per se. So that flow is a little bit different than actually being able to verify that information.
Mm-hmm. And so you would be probably giving them a Ladies First application and they would be signing up for the program?
Correct.
Yeah. And then you would be sending that into the program, and after the woman has left, and then where there needs to be some time is that our enrollment counselor receives that application and verifies the income and then loads the person into the system. My advice would be move ahead, because I know our program director has been committed. As long as you, as a champion, I'm not sure if you're the champion or whom you are, if your practice is well trained in the Ladies First program and you know our income guidelines and our criteria, we have all confidence in you that that woman is more than likely going to be eligible.
Okay.
Just that little bit of lag time that we had to get her in the system. Again, there's been mistakes where the woman is not eligible for the program. Maybe she didn't disclose all the information. Of course, you're going to have that, but I don't think it's going to be that big of a deal. 90 days.
Okay.
Yeah.
So at
the
that point,
also 90 days retroactive to the time that they apply. So.
Okay. So at which time we could actually schedule the mammogram and just let the person know to the hospital that they've applied for Ladies First.
Please do. And the thing is that what we can agree to is if the person was deemed not eligible, that we would pay for that service that day, but then, you know, we would probably have to do a manual payment on that, and then we would, but going forward, the woman would need to be assisted through another program or whatever was applicable. But, you know, we're just here trying to be supportive and help navigate the woman, not like, you know, sorry, that's it. You know, we've got this woman in, she could be hard to reach, you know, and you're doing your best trying to give her clinical care, and we're doing our best trying to help navigate the patient through the system. That makes sense?
Okay. Yes, absolutely. And can I just make one more comment?
Mm-hmm.
The doctors are going to benefit from the $100 because of the champions.
Oh, we know. We know. Make them take lunch once a month.
Yeah, we should say champion money.
Yes, absolutely. Thank you.
Yeah, you're welcome. Any other questions?
And I want to remind folks who may be on here but unable to be heard, I do have the chat box open. So if you wanted to post a question via that chat box, I will see it and I can read it out loud for you. Okay, are there Any other questions, discussion, things that might be useful to see in the future from Ladies First, for example, like for other trainings that we could do for you? Anything else that might be useful to you or your organization? For example, I was considering putting together a webinar for front desk staff on the eligibility of Ladies First Women and what to do if you find an eligible woman. Do you think that that's something that would be useful for your health center?
Hi, Kristen. It's Michelle, Rutland Community Health. I think that would be very helpful.
Okay, great. So I
would second that, Kristen. This is Jean.
Wonderful. Okay, perfect. So I will get started on that either this week or next, and I'll work with Nancy on that and tag all the appropriate Ladies First staff so we can get that together, and I will let you all know when that will be happening. Okay, so last call for questions before we wrap up, or suggestions.
And I will say from our side, thanks for coming. It's always helpful for us to practice our dog and pony show, whether it's in person or sitting in our cozy studio here in Burlington.
Okay, well, I believe that may be it. And if you think of a question later on, as always seems to happen, then feel free to email me or Nancy and Carrie, and we will get your questions answered as quickly as possible.
Super, thank you. Thanks.
So thank you everyone for attending, especially during your lunch hour.
Thank you.
Thanks.
Bye-bye.
Bye.